Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is going to be about ventilation tubes, also known as Grommet. In our previous class, we learned about the surgery on how to place these Grommet inside the tympanic membrane. We also discussed what are the steps and what are the complications of the surgery. Today, we'll be learning a little more about the ventilation tubes. What is the use of this? What material do we use to make it? And what are the different types of ventilation tube? You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, ventilation tube is this very small prosthetic tube which is open at both ends. This is an important part. And it is inserted through a surgically created myringotomy in the tympanic membrane. The other synonyms by which we know ventilation tubes as are Grommet, tympanostomy tube, and pressure equalizing tube or PE tube. Why? Because it is equalizing the pressure across the middle ear, which is the function of the eustachian tube. So, when the eustachian tube is not functioning properly and it is not able to maintain it is not able to balance the pressure, this tube is coming in and doing its job. And that is why it is known as PE tube. Now, what is the purpose of using ventilation tubes? Its main purpose is, first of all, is to ventilate the middle ear. Secondly, is to drain any effusion from the middle ear and prevent any accumulation of the effusion in the middle ear. And any symptoms that may be caused because of high negative pressure inside the middle ear as a result of eustachian tube function dysfunction, like like the pain, hearing loss, tinnitus, or vertigo. This tube is helping in alleviating all of these problems that have arisen because of high negative pressure in the middle ear. So basically, it is trying to fight back any kind of symptoms that can happen because of eustachian tube dysfunction. We know our main indication of ventilation tube usage is in otitis media with effusion, where the primary pathology lies in eustachian tube dysfunction, and as a result of which negative pressure is created inside the middle ear, leading to impaired ventilation of the middle ear and accumulation of fluid inside the middle ear. And to clear out that fluid, we use ventilation tubes. Now, what material is these tubes made up with? The more common materials nowadays are Teflon, stainless steel, silastic, even titanium is used, gold, polyethylene. Even though we do not prefer polyethylene, the most common ones used is Teflon usually, or even silastic. And sometimes material can be coated with silver oxide so as to prevent biofilm formation. And there's some newer material coming up, which is known as bioabsorbable or bacteriostatic Grommet. These are made of bacteriostatic polylactic acid. These are the newer ones that are out in the market, and they are a similar material to reabsorbable mini plates. So these are all the common materials with which ventilation tubes are made of. Now let's try to understand what are some features that every ventilation tube or Grommet has to fulfill for it to be considered an ideal Grommet. So first feature here is that it has to be biocompatible. What does that mean? It must be inert and non-toxic to the middle ear mucosa. It should not be inducing any kind of reaction like inflammation, fibrosis, or granulation tissue formation. It should also not cause any allergic reaction or foreign body reaction in the patient. So it has to be biocompatible. That is our number one important feature. Second is it has to be chemically stable. It should resist degradation, corrosion, and oxidation in the middle ear, and there should not be any leaching. So, this is second. Third feature is its mechanical strength and shape retention feature. So, it should have sufficient rigidity so as to resist any kind of deformation during the time you are inserting it or during the time it comes out of the tympanic membrane, that is, during its extrusion. It must retain its shape and the edges has to be smooth and atraumatic so as to not cause injury to any of the structures nearby. Next is it should have a non-adhesive surface. So the surface has to be smooth and non-porous so that it does not allow bacterial adhesion or any biofilm formation, and it reduces the risk of infection in these cases. So this is a very important feature as well. Next is it should be able to provide optimal ventilation and maintain its lumen patency. So the central lumen, if you will see the images of these tubes, usually this is what it looks like. So this central lumen that you are seeing over here, this is the outer flange, this is the inner flange, this is known as the waist. So this lumen that we are seeing over here, the central lumen has to be wide enough and it has to remain patent so that effective air exchange can occur. And this lumen should not get blocked easily by mucus, blood, or any debris. Lastly, the last feature of an ideal Grommet is that it should be easily sterilized using the standard sterilization methods like ethylene oxide or autoclave without any deforming or without any deformity happening to it, or without any loss of strength to the material. So these are all our features of an ideal Grommet that we should be looking out for. Now, next, let's talk about what are the different types of Grommet. Now, based on the duration of the stay that the Grommet is going to be kept inside the tympanic membrane for, the ventilation tubes have been classified into two types, short term and long term Grommet. First, let's talk about short term Grommet. Now, short term Grommet are the ones which usually remain for about 6 to 12 months before spontaneous extrusion. So, in short term Grommet, we do not have to do any manual removal at all. It spontaneously gets extruded sometime between 6 to 12 months. So, it serves a very short term purpose. What are these purposes usually? Usually, the cases like chronic otitis media with effusion or recurrent acute otitis media cases. The material preferred for this are usually Teflon, polyethylene, or silicone. And coming to features of this, they should be small and lightweight so that they can be easily extruded out by the normal epithelial migration of the outer layer of the tympanic membrane. And they should have a minimal risk of persistent perforation. Now, if we look at these images here, these are some common short term Grommets that are usually used. The first one, Shepherd Grommet, is the most common Grommet that is used. You can see that this is the classic bobbin shaped, this is the outer flange, and this is the inner flange. The inner flange is placed towards the middle ear, and the outer flange lies in the external auditory canal. And so this is the central lumen which maintains the ventilation. This is the most commonly and widely used. And a very important feature here is that it extrudes within 6 months of putting it in. So Shepherd Grommet is the most common one. The second one over here is Armstrong Grommet. You can see that it has a very short barrel-like design and very small flanges. It is also again a very commonly used one, and this one causes very minimal trauma to the tympanic membrane. Third one here is a Shah Grommet. You can see the structure is a little different here. The flanges are conical. If you see this one, this flange, the inner flange is actually triangular shaped. This helps in retaining the Grommet inside the tympanic membrane for longer. And this is usually made of Teflon. And the last one over here is Paparella type 1. You can see this is a short barrel-like structure with a notch over here. This notch helps in easily holding it and putting it inside the tympanic membrane. And this extrudes usually by about 12 months. So that's about the short-term Grommet. Next, let's look at the long-term Grommet. So long-term Grommet are usually the ones that are retained inside for about 12 to 24 months or even longer in certain cases. Now, usually the clinical use over here would be more long-term purposes. Like, for example, in recurrent otitis media with effusion, after multiple times we have used short-term tubes and it keeps on extruding out and the symptoms start recurring. In these cases, we'll put in a long-term Grommet. In cases like cleft palate patients or palatal palsy patients, or even in patients with craniofacial abnormalities, will prefer to put in a long term Grommet. Other than this, also in cases like adhesive otitis media and severe eustachian tube dysfunction. Material used here is usually silicon, Teflon, and even titanium. Features of these long term Grommet is that they have a larger lumen and a wider inner flange. Why? Larger lumen so that it maintains the patency for long and it does not get easily blocked by blood or mucus, etc. And wider inner flange will help to retain it for longer and prevent any spontaneous extrusion. These tubes may require manual extrusion after 18 to 24 months if it has not extruded out itself. And another feature of this is that it also carries a higher risk of persistent tympanic membrane perforation as compared to the short term tubes. Now, if we look at some examples of these tubes, the first image that you're seeing over here, this is the Gooday's T tube. This is the commonly used long term tube. As you can see, this is T shaped with two long lateral flanges which try to prevent the extrusion. This tube often needs to be removed manually at the end of 18 to 24 months. Second is known as pearly tube, which is made of silastic or Teflon. This is a modified T tube with a wider lumen. And third example is Paparella type 2. We saw that Paparella type 1 was a short term tube, but Paparella type 2 is a long tube which has a large inner flange. It is usually retained for a long period of time, about 2 years. This is typically used for adhesive otitis media cases. So that's about the different types of ventilation tube that we know and different examples of it and how they look like. Next, we'll talk about the indications of Grommet insertion. Now, the most common indication over here is otitis media with effusion. But does all cases of otitis media with effusion require this? No. First, if you have looked at my video on OME, you will see that our main primary management is to observe the case and give medical management. Only when the patient does not respond to medical management do we go for Grommet insertion after myringotomy. Such cases would be in cases of chronic otitis media with effusion, which is not responsive to antibiotics and it has persisted for more than 3 months when it is bilateral or more than 6 months when it is unilateral, or even earlier if the hearing loss is more than 25 decibel. Second is cases of recurrent acute otitis media with effusion, where we have at least 4 episodes per year. And third is any acute otitis media with effusion which is complicated, for example, having complications like facial palsy or vertigo. So these are the indications within OME for putting in a Grommet. Other than this, we have a lot of other indications as well, like recurrent acute otitis media. How do we define the recurrence over here? When there is more than equal to 3 episodes in 6 months or more than equal to 4 episodes in 1 year. In cases of adhesive otitis media, atelectasis of tympanic membrane, persistent retraction of tympanic membrane, hemotympanum cases which are not spontaneously resolving, patulous eustachian tube causing autophony, and chronic eustachian tube dysfunction, otitic barotrauma which is not responding to medical management, and intractable Meniere's disease which are having severe attacks of vertigo. These are all our indications for using ventilation tubes. Next, let's talk about what are the contraindications of using ventilation tubes. So, first contraindication is if the patient has an only hearing ear. We have to be very careful in these cases because since this is the only hearing ear, uh, Grommet insertion can also have its postoperative complications. Like you may risk total deafness in a patient who has only one ear. So, only one hearing ear. So, in these cases, unless absolutely required, we will try to avoid doing it. But if it is absolutely required, then we should take informed consent from the patient and explain to them the possible postoperative complications and what is the risk over here before we do the surgery. Second contraindication is having an intratympanic glomus tumor. Because glomus tumors are very highly vascular tumors, any chance of injuring the glomus tumor will lead to catastrophic bleeding, which will be very difficult to control. Third is having a dehiscent jugular bulb because jugular bulb lies in the floor of the middle ear. When you're giving an incision in meningotomy incision in the anterior-inferior quadrant, if you are giving an incision which is too inferiorly placed, you risk injuring the jugular bulb, and especially if it is dehiscent, then it can get injured easily, leading to catastrophic hemorrhage. Fourth is middle ear neoplasm. Fifth is acute otitis media, which is a relative contraindication. So, if the otitis externa is present at the time of surgery, we should try to avoid it and first treat the disease before performing the surgery. But in case if it is absolutely required, we can start the patient on antibiotics and take them up for surgery. The reason why we try to avoid is because if acute otitis externa is present at the time of surgery, it leads to increased risk of postoperative infection. Next contraindication is having an atrophic tympanic membrane. Atrophic meaning where the tympanic membrane gets very thinned out. In these cases, the thinned out tympanic membrane will not be able to keep the ventilation tube in place. It can easily get displaced into the middle ear, and it can also risk a permanent perforation in these tympanic membrane. Next is if we have a stenosis of the external auditory canal. Now, if the external auditory canal is narrow or stenosed, in these cases we will not be able to access the tympanic membrane to do the myringotomy and insert the Grommet tube. Therefore, that ends up being a contraindication. And last contraindication is having uncontrolled systemic disease, because in uncontrolled systemic diseases like diabetes mellitus or hypertension, the patient has an increased anesthetic risk and increased operative risk as well. So we'll try to avoid in these cases as well and try to first treat the general condition before going ahead with the surgery. So these are our indications and contraindications of using ventilation tubes. Last of all, let's also learn what are the complications of these ventilation tubes. So we can divide the complications into intraoperative and postoperative, and postoperative can further be divided into early postoperative and late postoperative complications. So, coming to intraoperative complications, the most common one is bleeding, which can happen from injury to any vessels in the tympanic membrane. But this is usually self limiting and can be easily controlled. Second is the tube may get displaced into the middle ear during the time of surgery. If that happens, what we should do over here is we should instill saline into the middle ear through the myringotomy incision. This will result in the tube floating up, and then we can suction and retrieve it out. Third is we can cause a lot of injury to multiple structures. So one of the structures is ossicles and incudostapedial joint. If we try to give an incision in the posterior superior quadrant, we can end up injuring these structures. Therefore, we avoid a posterior superior quadrant injection. Instead, the site at which we give a myringotomy incision, sorry, not injection, myringotomy incision is the antero-inferior quadrant. Next, we can also end up injuring the facial nerve, however, which is very rare. But if it has happened, the tympanic segment is the most common segment to be at risk because it lies in close relation to the posterior quadrant. And patients who have a dehiscent facial canal are at an increased risk of injury. Next is we can end up injuring the high riding jugular bulb, especially if the jugular bulb is dehiscent. So, in these cases, we can end up injuring it, leading to a catastrophic hemorrhage. Lastly, we can end up injuring the oval and round window if the instruments are introduced very deeply or if we try to suction near the promontory. This can end up in causing sensory neural hearing loss or vertigo. So, these are our intraoperative complications. Next is the early postoperative complications, out of which the most common one is otorrhea or ear discharge. This can happen because of middle ear infection or any pre-existing infection in the external auditory canal, or if enough asepsis has not been maintained during the time of surgery. We treat this with topical antibiotic drops. Second complication is blockage of the ventilation tube. This can get blocked by either the blood clots, the mucus plugs, or debris, and this will defeat the purpose for which it has been placed. So, how will we treat it? We can microsuction it or place some hydrogen peroxide drops or even remove it if it has been persistently blocked and replace the tube. Patient can also complain of some pain and irritation, which is very common. Usually, it's very mild and self limiting, and we do not need to do anything about it. Patient can also have otitis externa, which is infection of the external auditory canal. In these cases, we should perform oral toileting and place topical antibiotic steroid drops. Next is premature extrusion of the tube. So the tube is supposed to serve a purpose, like for a specific amount of time. In case of short-term tubes, it is 6 to 12 months. In case of long-term tubes, it is 12 to 24 months. So if the tube gets extruded out prematurely, in those cases, what could be the reasons? The reasons could be either because of infection or because the size is incorrectly placed. So, in these cases, we usually reinsert the tube in case we see that the patient's symptoms have come back after the extrusion of the tube. Next is there can be granulation tissue formation around the tube. This can occur because of chronic irritation. How do we treat it? By either cauterization or removal of the tube if it is recurring multiple times. Last early postoperative complication is if the tube gets displaced into the middle ear. Now, because this is happening in the postoperative period, if we find this out after the perforation has healed, we can consider leaving the tube inside because usually the material is biocompatible and it does not cause any foreign body reaction. Last part is the late postoperative complications. So, first complication in the first image that you're seeing, this is a permanent perforation of the tympanic membrane. This happens sometimes after the tube gets extruded out, the tympanic membrane fails to heal. This risk is higher in case of long term tubes and repeated insertion of tubes and in infective cases. We may need to perform meringoplasty to treat these cases. Second image over here is that of tympanosclerosis, also known as meringosclerosis, where we see this whitish chalky deposits happening because of hyalinization and calcification of the collagen around the site of tube insertion. Usually, this is a very common complication, but we do not need to worry too much because the functional hearing loss is not as much. A third complication over here is an atrophic tympanic membrane. You can see how the tympanic membrane has been thinned out. This can happen when repeated procedures have been done or chronic inflammation has occurred over here. And last complication is a retracted tympanic membrane, which can actually end up in predisposing to form cholesteatoma. So this is all about ventilation tubes that you need to know. If you have any further questions on this, please note them down in the comment section and I'll get back to you. Thank you.